So welcome to a three-part series, Immediate Full Arch Reconstruction with Guided Surgery and Prosthetics. It is being presented by Dr. Douglas Diddy, DMD, MD. Tonight is part one, case selection, and we are going to begin the webinar shortly. And now it is my pleasure to introduce Hallie Warwick, Director of Sales, Implant Solutions, and Guided Surgery. She's here this evening to be your support and introduce our guest speaker. Take it away, Hallie.
Thank you. Good evening, everybody. Today, I have the pleasure of introducing to you Dr. Douglas Diddy. He is an oral surgeon practicing in Delaware. He has been named a top doctor in Delaware today each year since 2006. His practice focuses on TMJ, implants, orthognathic, and most importantly, full mouth reconstruction. He has been using our digital workflow with NDX and Sequence for over 5 years and hundreds of arches. We're thrilled to have him present this evening. Dr. Diddy, the floor is yours.
Hi, everyone. Good evening. Thank you so much for attending this lecture. I'm very excited to be here and discussing one of my favorite topics. As she said, my name is Douglas Diddy. I practice in Delaware. I have 3 practices located in Delaware, and I graduated University of Pennsylvania Dental School in 1999, and I have been teaching there ever since part-time. I attended my oral surgery also at the University of Pennsylvania. Tonight, we are going to discuss full arched fixed implant restorations with immediate loaded prosthetics. There are so many different names for this, and we'll get into this a little bit. And this is part 1 of this series where we will have a little bit of blood and surgery and prosthetics. And then part 2 will be a lot of blood with a little more surgery and prosthetics. And part 3 will be complications and will be very cringeworthy. So hopefully you'll stick with us for all 3 lectures. I teach both dental students and residents at the dental school. And I've been interested in this in tooth in a day type procedures for a long time. A little housekeeping slide. Moving on, this is called the Delmarva Peninsula, and it consists of Delaware, Maryland, and a little bit of Virginia at the bottom. My practice is in the center of the state in Dover, and also down at the beach area, as well as the west side. And you can see that there are major metropolis areas around us with Washington, Baltimore, Philadelphia, and even New York City is not very far away. So there's access to a lot of good labs around here. And I started doing these cases over 10 years ago, working with local labs. And I will try to show you that right now my preferred lab is definitely in Sequence. I'm a believer. I've changed things as I've gone. I've tried to improve my practice and get better and better. And I hope to show you today the digital workflow that I use within Sequence and the advantages that the digital workflow has. I have 2 cases here that I promise will show some points I want to make. This is a case where we tend to look at just, 1 tooth at a time. The patient fractured their tooth. We removed the tooth. We placed an immediate implant. Great. Everything went perfectly fine. But I do want to point out the X-ray on the right side of your screen. And I want to remind you all to look at the surrounding area, not just the tooth we're working on, but try to really evaluate the teeth around where we're working. Look at the quality of these teeth. Seems like there's a lot of dentition and poor repair, and maybe sometimes we need to think bigger. And partly what I wanted to talk about is terminology. So placing an implant directly in a socket is an immediate implant. And I'm sure some of this is very basic for you all. And we will have some tips that are very basic, some information basic, and some that will get, more and more complex for the people here that really are already very knowledgeable of this. Placing a temporary directly on an implant, we call an immediate temporary. There's a lot of terms immediate that we're throwing around here, but this is out of occlusion. This is a chair side made temporary and the final crown on the right. But again, did we do this patient a service to place one single implant without looking at all the surrounding teeth? Look at 6 through 10. There appear to be fractures and recurrent decay. Look at number 12. There seems to be a vertical root fracture on number 30. It is possible, and hopefully it was discussed with this patient, that maybe we should think bigger and take out more teeth and either do bridges or possibly even a tooth in a day case. I'm going to use the term tooth in a day fairly frequently to describe this type of a process of removing all of somebody's teeth, placing implants, and placing an immediate load prosthetic. This is a fractured tooth number 9. And one of the other themes of this entire discussion will be why digital? What does digital do for us? I took out number 9 and I did an immediate implant, but this time I guided the implant. I had a discussion with my business partner recently where he said he doesn't like to use guided cases because his guides never fit properly. He always has problems. But I would say that there's an unfair bias in that he's using these guides when there's no way that he could place the implants freehand. And so he already knows he can't place the implant freehand, and is very difficult sometimes. Guides are not perfect, especially in those situations. But here, I would say that if we place this implant 99 times through a guide, most of the time, as you know, we will have near perfect placement of this implant exactly where we intended it to be, including coming out of the cingulum area, which is where we want it, because of what I'm about to do next. We place the implant, and this is what we can accomplish with digital type of a workflow. This tooth number 9 was created by a lab. However, it was created by a lab from our implant plan, where we were able to create the implant in the model. And this lab fabricated temporary already has the abutment built into it. So it took me approximately 10 seconds to place this implant crown. And there's no way that we can accomplish anything like this manually. So the middle photograph is after 1 week, and the photograph on the right is after 3 months of healing. So now we have a simple case. Well, not so simple. We have a double arch case, but it's a good case. This patient has a poor dentition, excellent attached tissue, does not appear to have periodontitis, appears to have plenty of bone. And although it's complex, and we'll get into the details of the complexity of how we do these cases, when it comes time to do the surgery, I try to ease my patients' minds by telling them that really all we're doing, we're removing their teeth, we're placing implants, and we're going to screw on new teeth before they go home. Unfortunately, it's really not quite as simple as that, as you all know. I want to point out that I want to go back to this slide for 1 second. This case I'm going to do with in sequence with my preferred lab. And We placed, as you can see, a lot of implants here, large implants, and the upper maxillary implants are angled. We have some angled implants. We'll discuss this more in a little bit. This took me an hour and a half per jaw using digital. And this is the immediate result after I've inserted all of these teeth prior to any occlusal adjustments. And I have to say that I've been doing these cases for a long time using conventional labs, and I've never been able to have such consistency with getting good occlusion. This is an important thing. Getting the proper height of our device between 12 and 16 millimeters, depending on what type of final prosthetics we want. The other consistent part with using digital is having the transition line of the device hidden above their smile and the incisal display in the position that we want in such a short period of time. Let's talk a little bit about some of the other confusing terms. So this is when we do this immediate load. This is now immediate load. So it's yet another immediate term. You've heard the term tooth in a day, and I'm using that term a little bit today. This was coined by Tom Balshi, who is a doctor that around Philadelphia, a prosthodontist that developed this and wrote a lot of papers and did a lot of research on this. And we have another term, tooth in an hour. These are protocols and somewhat gimmicky terms to get patients in your door. There is such a thing as tooth in an hour, but I will explain that shortly. The terms on the bottom, 1-day implant, all-in-4, DM, Teeth Express, these are all branding for dental implant companies. These companies all have their own name for the same thing, and they want patients to know these names so that they can Google these names and get directed directly to a doctor that places their particular implant brand. The history was, one of the first papers was 1997. And again, one of the reasons why I have been so interested in doing these cases, and I've been doing these cases for a long time, is because Glenn Wolfinger was one of my instructors who taught me a lot about implants. He worked at the VA hospital, which is part of the University of Pennsylvania system. And I got invited to go see them do cases back in 1997. And the other thing that got me interested was the fact that I actually got to restore 2 full arch hybrid cases when I was in dental school, which is highly unusual back then. I just got very lucky. But some of the key concepts that he developed were cross arch stabilization. That's why we can immediate load cases, because we have implants on both sides of a horseshoe shaped arch. Angled implants are also key to helping the mechanics of certain cases. Not all cases, I'm sorry about that. Not all cases do we need to angle. And at first they used 10 implants. And tooth in a day is traditionally done. The actual real term tooth in a day, what it means is what I call a conventional lab method of doing this, where we create a denture, and that denture has to be made perfectly with the proper occlusion, the proper smile line, occlusal plane. And then we place the implants under the denture. There's many different methods of doing that, both, freehand and guided, to get them in the right place. And then we have to convert that denture by drilling holes through it at precise locations and mounting it. And this is key, mounting this in the correct vertical position. The really difficult part with conventional cases is mounting this in the correct vertical position, and be able to remove bone the proper amount so that your device is the 12 to 16 millimeters that you need. So extremely difficult, I will say, with conventional labs to do this, although it can be done, and there are some great labs out there. Tooth in an hour is all digital. This is really a very specific type of digital case where the bone is already at the proper height. And really, everything is perfect. There's enough bone. So I believe something like this can be done within sequence. But essentially, we're just making a soft tissue guide, tissue punching, placing the implants, and already have a prefabricated device, prosthetic device to put on top of that. It's more of a marketing term. Or if you all want, this is a photograph of Delaware and my kids from actually many years ago. My oldest is now 18. But you can use my term that I made up that describes this perfectly. And I want credit for this if you use this in your practices. Are you ready? Immediate load, full arch implant restoration with immediate loaded healing prosthesis with enough implant support and cross arch stabilization. That will take anywhere from 1 hour to 8 hours, but with an extensive period of pre-planning and post-op healing before the final prosthetics are placed. That is exactly what we're doing. And if you forget when you're presenting this term in your office, I've got a mnemonic for you so you can remember it. Now I want to discuss some of the main principles of doing these cases. We discussed angulated implants and getting enough implant support. Well, doing this type of procedure with implants and immediate loaded prosthetics can be done on 4 implants. We've all heard of this. And in this case, we didn't have a lot of bone. And I'm not knocking doing this on 4 implants. These procedures work. And the reason that they work is because we're angulating the implants. Technically, these anterior implants should be angulated a little more anteriorly so it looks like the letter W. But by angulating the implants, we're allowing for very long implants, much longer implants than we can place if they're not angulated. But also, very importantly, we are getting a better anterior posterior spread. And the mechanics of this is very strong to hold up in immediate loaded prosthetics. On the top jaw, we want the implants to look like the letter M. And this works. Some critics argue that if one implant fails, the whole thing fails, though, because it's difficult to have full arch loaded prosthetics on 3 implants. I think you need to determine this based on your patient, based on many factors: the quality of the bone, the amount of teeth you want in your prosthetics, the type of final prosthetics, whether the patient is a bruxer and grinder. The concept of anterior posterior spread is still a very important concept for these types of immediate load devices. We need our implants to have a good anterior posterior spread, and we don't want to cantilever a whole lot, especially on the initial prosthetic immediate load device. We used to say that you can extend your cantilever 1.5 times your anterior posterior spread distance. However, there's a lot, there's really no evidence of this. And now a lot of the literature is saying that you really need to base your cantilever off of many other factors, such as how heavy your patient's bite is, how much implant support you're able to get on this device, and many other factors. Health of the patient is another thing that is very important, another consideration in these cases. We all know about the general health problems of, immunosuppression or radiation, but I have a photograph here of smoking. Smoking is not a contraindication for doing these cases. But I will say that implants of smokers fail more often. They get more periodontitis or implantitis afterwards. And the bone is softer. So if you have a patient with, say, smoking and very little bone and a very strong bruxism habit, this will not be a case that you can do an immediate load to prosthetics. You may still be able to do a hybrid and place your implants and end up with the same prosthesis later, but you may not be able to do an immediate load prosthesis. A lot of patients grind and clench their teeth. Many of my patients that I've done these cases for do this, but you know who your severe bruxers are. And for your severe bruxers, you know there's a lot of wear of the teeth. You can see very large masseter muscles. And these patients, you may be able, this is not a contraindication, you may be able to still do a case like this, but you need to have enough implant support for these prosthetics, and they can break these plastic devices. I know this is a little extreme, but this is a real case that I was sent to do a procedure like this. And I know this is obvious, but there's too much periodontitis to do a case like this in immediate fashion. And I hope you're all awake now. And this particular patient was able to change some of the social things going on in her life. And we removed her teeth, let everything heal. And eventually we came back and did immediate loaded prosthetics. Here's her smile. Another case where this young lady has also changed her lifestyle. She has an upper denture and lower decay teeth. And this is a very important factor for these cases. Inadequate bone. Inadequate bone is something we really need to figure out a way to work around. One of the methods is to do zygomatic implants, which I've been doing more and more of lately. Or in this young lady's case, we did some bone grafting. So a few more bloody pictures for you. I like in these cases to pull out all stops, and I will use autogenous bone. I will use cadaver bone. I will use tenting screws. I will use growth factors. I will use collagen membranes, all on the same patient to attempt to regrow the bone. And I was able to get just enough to do this procedure, but I still did not feel comfortable doing an immediate loaded upper. And eventually she has her loaded acrylic. These are all acrylic or PMMA. I think these were PMMA. Yeah. Upper and lower immediate loaded devices. And this is her final. And again, I want to point out that this is where the incisal edge is for her smile. And we need have enough vertical height of the prosthetics. And we have the transition line of the prosthesis hidden above her smile. Poor dentition, good bone, good attached tissue, excellent candidate to do this procedure. This is a very straightforward case. And yes, there are a few little gaps underneath this device, this prosthetic device we place on here. Yes, it's nice for the patient to be able to chew when they're leaving and have fixed teeth in place. But the other reason for this is for the patient to decide what they like and don't like as healing takes place, because they can have things changed with the final, whether they don't like the color or the shape. And also the bone and the recession that will take place, the remodeling will take place underneath this plastic device. And then the final can be made to where all the tissue settled. I will also caution you against doing these, or be careful. This is not a contraindication, but careful with patients with severe skeletal discrepancies, such as a skeletal class 2. May not be able to do an immediate load because they'll be biting mostly on the posterior portion of the device. This is an orthognathic case I did. This is another orthognathic case I did where I'm using it as an example to show you a few things. A skeletal class 3 patient. The reality is she had maxillary hypoplasia, and I did a Lefort 1 advancement. But many of my patients come in after years of not having teeth and wearing a denture, and when they take the denture out, this is what their upper lip looks like. And those patients can sometimes use lip support. They may not be able to have a hybrid prosthesis. They may be better candidates for having a bar overdenture so that they have a buccal flange for lip support. So I will bring up lip support several times as we go along here. Also, if you need to be careful with this situation, if you place the implants and design the prosthetics, let's say you do an uppercase, you may not be able to angle your implants enough to get your prosthetic teeth in an appropriate class 1 position. They may be in an anterior crossbite. And I always want to bring up adequate soft tissues. I do believe very strongly in having enough, very important for us all to be mindful of, enough attached tissue, nice, thick, healthy attached tissue around your implants. Implant failures do happen, and these are 2 implant failures that I've had or seen on the implants on the right side of the screen. Sometimes we blame this on things like cement in the sulcus. There is cement on this implant, but I don't think that explained this implant failure. This implant failed way too soon, and this happens to the best of us. This was a nice big implant. There's no reason for it to fail, but it still did. The implant on the right is something where I can make a living off of 4mm implants supporting molars because they do work many times, but it is also common that it's not enough support for this large tooth that is required for a molar. It's the basketball on a toothpick effect. So heavy occlusal forces with not enough implant support does lead to failures. Underneath a immediate prosthetic or a hybrid, the most likely implant to fail would be the distal implant. Part of the theory is that it is the posterior part that's taking the most forces during chewing, and the implants in the posterior region are usually in a wider ridge, which are more likely that the implant is in more cancellous bone and not engaged with the thicker cortical bone. I will say that the one absolute, for me, contraindication is recreational drug use. Non-compliance is very difficult to assess of your patient beforehand, but recreational drug use, sometimes you can. And this is an example of my biggest failure, and fortunately the only time this has ever happened, was a young lady with a recreational drug use problem. We did the case. She never came back. 1 year later, came back to my office with pain. We couldn't get her in. She never answered our phone calls. And this happened. So we need to figure out our final device. They're encouraged to follow through. Every time I do a lecture on dental implants, I have sort of 3 parts, and it's very similar to a lot of the courses you take where if, and I tailor this to different audiences, but there are 3 parts for every single implant lecture I do. There's the preparation, the 3 Ps, we do the preparation, which is essentially our initial evaluation and overview. There's our planning phase, which is when we're really getting into the nitty-gritty of the actual developing the case and working with a lab at that point. And then there's the placement phase, which is all the surgical phases. So the preparation, the beginning phases of these cases start with three things that your techs can do: photos, x-rays. You don't always have to do a cone beam CT scan here. You can, if you are not sure if you can do this case or if there's enough bone. I'm trying to get away from doing a cone beam CT scan at this phase if I can see that there's adequate bone. That is so that I save the patient some radiation, because we absolutely have to do a cone beam CT scan at the planning phase later, which I will show you, and then a scan or models. The clinician yourselves need to evaluate the periodontal health and all the things we just discussed, the health, the cosmetics of the patient, the dentition. The special considerations are all the things I just discussed: the AP spread, adequate bone, lip support, and patient preferences. Now, patient preferences are things that we need to ascertain during our initial consultation with these patients. And one of the main ways we can do that is by showing them photos of different options and showing them and having models in your office. So I would advise you all, anybody who's interested in doing these cases, to have models and get some pre and post-op photos. While working with a in sequence, a digital lab, these are the 5 things that are required. What I love about in sequence is that they are collecting your items and they are evaluating them for you. So they will keep a folder, they will keep all these things in the folder, and you need, they will let you know what you still need. And one little pro tip, one advice I have for you all, is if they say that one of the scans or intraoral scans or CAT scans or photos isn't good enough, heed their warning and redo it. And I would, tell you all to discuss this with your patients, that we're going to have some back and forth until we have this right, that there's going to be extensive pre-planning period until we know it's going to be perfect for you. A very, very important thing, which I'm going to discuss very shortly here, is that you need to fabricate occlusal splints or wax rims if your incisal edges are not in the proper position and if your vertical is not where you want it. For photos, this is self-explanatory. Use mirrors, use retractors, get a good camera if you're going to do a lot of these cases. Although I will say the left picture does not look like the right picture. It is the same patient before and after. So take your before and after pictures so you can actually educate patients, show them what types of what you're talking about when you discuss a full arch case. These are the 5 very, very important photos that you need when doing these cases. Very important to be able to show the incisal display at full smile and at repose. You can also add a 6th photo of a Duchenne smile where you have a very, very exaggerated smile response. From here, this is part of the digital planning phase where we want to really plan from the incisal edge. Not wrong way. I also encourage you all to invest in digital scanners if you don't have them already. At least in my practice as an oral surgeon, sometimes oral surgery assistants' impression-taking skills are a little suspect. And I've had, for example, my sleep apnea devices, the fit of my sleep apnea devices since I've purchased a digital scanner is pretty much night and day to where I was before when we were taking manual impressions. And every little detail matters for these cases. The more accurate we are, the better your case is going to turn out, because small errors are cumulative. So taking a digital scanner is getting accurate impressions, very, very important. Make sure you extend into the vestibules and try to get the entire palate. Many times you want to have a backup denture fabricated, and in sequence can digitally print a backup denture that will come along with the case, so that heaven forbid the implants never. That's another tip for you: never promise a patient that you're going to give them immediate loaded prosthesis. Tell them that you're going to do your best to do that, but never promise that. And when in doubt, have a backup denture ready. This is initial cone beam scan, although the reality is with somebody with this much bone, I wouldn't take an initial cone beam scan. As a matter of fact, you can see that this was actually my later planning scan because I have radiographic markers. When do we do immediate loaded hybrid? This is a very important slide. There's a lot of words. Sorry about that. Everything is adequate. They have to have good bone. They have to have good soft tissue. This is also a case, though, where if they do have excellent bone and in the right height, you can also offer to do fixed bridges instead of a hybrid. But is not usual that you can do immediate loaded hybrid and then turn it into fixed bridges, because you have to do too much bone reduction for a hybrid. And if you don't do that bone reduction, your initial temporary is going to break. Obviously, failing dentition, periodontitis with caution. You can try to do a good cleaning and clean this up in Paradex and try to clean up some active periodontitis before you start. When a patient cannot wear removables, a good candidate. And I will discuss in a few minutes. Make sure you see the cases. This goes back to when we were looking at the surrounding teeth earlier. If you don't look for these cases, you'll never see them. And they're out there. There's a lot of these cases right in your practice. It's good to present the case. It doesn't mean that a patient has to say yes, but at least you've given them the option. Are you a believer in this type of a work? I am. I'm a believer in this. I'm passionate about this. I see the happy faces. I see the lives changed. It is such a good product. Having fixed teeth in somebody's mouth. I'm a believer. It's easy for me to talk to patients and tell them how nice these are and how, what benefits they will have to their life from, nutrition, cosmetics, social. In order to get patient acceptance, we have to have teaching models, as I said, before and after pictures, and you are going to have to figure out costs and your own, what you're willing, what you're going to charge a patient. Another benefit of these devices, immediate load hybrid, again, if done properly with enough implant support, cross-arch stabilization, everything we said, this really, the vast majority of these cases should last forever. If you also, especially if you pick the correct prosthetic materials at the end, we can't underestimate the value of maintaining their bone. And you can talk to patients about what their faces will look like 20, 30 years from now with no implants, and how important it is to wear something fixed and feel that proprioception. I feel that this is an important slide because this really is how I gain patient acceptance to these cases. Fixed, I don't know too many dentists that are wearing removable devices. And so if we all want to wear fixed, why not present them more often to our patients? Here is my models, and I also advise you to have a model of a bar overdenture because sometimes you just need the flange. See the cases so we don't end up over implanted like this patient. I was referred this patient to place an implant at, I think that's number 9. And yes, I did it. The other option was for the restorative doctor to remove the teeth on the adjacent implants and do a bridge, but they couldn't figure out what types of implants these were. But I also want to say that if we see these failing teeth earlier, we should discuss full arch cases with our patients earlier. Look at the bottom teeth. They're already failing teeth down here everywhere. This is a perfect time to bring up a immediate load full arch case, and actually it will save them a lot of money from what they spent on the top jaw. The last tip I want to say about this is let's also not judge our colleagues for doing things like this because we weren't there. Their patient may have made this decision to only be reactive and do one tooth at a time. And I believe there are 4 different types of implants in this patient, which also means they were going to many different providers. Another case where we should be discussing all of these teeth that are failing and including either doing bridges all the way across or possibly a full arch case. It is also very difficult once we've placed this many implants to do a full arch case because these implants aren't always in the correct position. Now, my guess is I would be able to use some of the implants, but others we would not be able to use because there's not proper vertical height. So we can't always just convert all that easily. Now here, maybe we can be a little bit judgmental about the dentistry, but I still think we need to keep our mouths shut with our colleagues because we've all had problems. But the teeth weren't seated properly on these implants. An implant was drilled into a tooth. All of the other remaining teeth are failing, and this patient was never offered a full arch prosthetics. We will spend some time on this slide, and we already discussed having a global fee versus separate billing for your offices. Global fee is a little easier if you come up with what your global fee would be with you and your whoever you work with, or if you're doing it all yourself, come up with what your fee would be versus separate billing for the surgery, separate billing for the prosthetics. One thing to know is that in my experience, the profit margin for the prosthetic part is much, much greater than the profit margin for the surgical part. And it is one of the reasons why some of my business partners don't do these cases, because it still takes them hours and hours to do the surgical part. And I've been able to get the time, time is money. How many wisdom teeth or implants, or how many implant crowns can you seat in the amount of time it takes you to do the surgery? If you think about it, if it's going to take 6 hours to do the surgery, it's very difficult to be actually profitable for you. And I've worked on ways to get it faster and faster. And the best way with really precision and perfection is really using digital. I've been able to get these cases down to approximately an hour and a half per jaw. And from start to finish, I mean, inserting the immediate load temporary at an hour and a half or before an hour and a half, I feel that makes these cases worthwhile and profitable for me. If you're interested in doing these cases, great. You're going to have to start slow. You need to start somewhere. Make sure you block off pretty much all day to do these cases at the beginning. But the point of this, is that conventional and digital, you need to compare apples to apples when you're looking at expenses. In my experience, they're both about the same. And the digital lab comes with extra parts and pieces, and including a surgical guide comes with it. So, you know, if you do a conventional cases, you have to do your own surgical guide. And my little pro tip is I never analyze the wallet of the patient. Doesn't matter what they look like or who they are. They all get offered this type of a, you know, treatment plan if their case warrants it. And you'll be amazed which patients actually go through with it. Other expenses, implants are expensive. Low profile abutments are very expensive. Your drills, your bone graft, collagen, temp gold cylinders, titanium screws, lab techs, chair side is very, very important. Again, time is money. I don't have time to sit and do all the prosthetics. I'm finishing the surgery while the lab technician is finishing their part. And pretty much by the time I'm finished with my stitches, the teeth are ready to insert. And I don't have to spend the next 2 hours trying to, you know, work on the immediate load prosthetics. So to me, very worth it. And also in sequence, these chair side assistants, they have seen these cases. They have been through these cases. They have advice for you. If there are problems, they can help with problem solving. So now we are in the planning phase. And we want to start, and very, very important, with our wax up, well, not a wax up, sorry, some type of wax up or software planning, our bone evaluation, our implant. This is when we're actually doing the implant positioning, and we are fabricating our temporization plan, our backup dentures, our final prosthetics, and whatever compromises we will make, such as maybe sometimes we take out teeth on the initial load prosthesis, so that's not cantilevered back very far. And very important as part of the planning phase, we need to create, if we're going to change the incisal position or the vertical height, we need to create waxed rims or occlusal rims or some type of occlusal splint before your cone beam scan. It is up to you as the clinician to establish your vertical, your incisal edge, your desired occlusion picture, and joint position. Now, within sequence, this is very easy because you have a lot of very experienced people that basically, and engineers that will help design these cases. When I'm using conventional labs, the lab will create a perfect denture, but it is 100% up to me to figure out how much bone I need to reduce to get enough clearance for our 14 to 16 millimeters, depending on what type of final device we want. This is very, very challenging, and very challenging to, you need to find a very good, and there are good, you know, I'm not knocking conventional labs. There are very good labs out there. I've worked with, I counted the other day, and I believe it's 6 different major labs around this area. The problem is that all of them do these cases, but they're all a little bit different in how they do these cases. And I found some that do an excellent job, and but I can't. It is a lot more difficult for me and more time consuming, and that's in my hands. I do recommend you use articulators for mounting these cases. And, you know, once the teeth are gone, you know, you're taking your occlusal record in where you want the teeth in the most comfortable position or centric relation is very important, because once the teeth are gone, they're going to put their teeth in the most comfortable position. So your workup is very important. You're preparing for your scanning by creating your splint or your wax rim, determining your incisal display, and making sure your patient is wearing their splint. In other words, if the incisal edge is not where you want it, or within 3 millimeters of where you want it, you need to create some type of occlusal splint or a wax rim to put it there. This is in their mouth during their scan. And now finally we can do our scan. We are going to put scan markers on either the denture. So the denture may be made, if that incisal position is correct, then use the denture as your wax rim and put the stickers on the denture. You need at least 6 stickers per arch. And you're going to scan the patient with this in their mouth in full occlusion. And then this is the dual scan technique where we then scan this separately. This data all gets married together, and the software in sequence will do this. Essentially, be prepared for your scan, because this is the definitive scan that you really want your planes of occlusion correct. Use articulators, use whatever it takes to try to get your occlusion planes exactly where you want them. It will save you a lot of headache. You can also correct it again. You have a second chance after the initial device. You have another chance to make corrections with the final device, but it's a lot easier and better if you can have everything done before the initial device, and then your final restoration will go so smoothly. Now, if you're using a conventional lab, you're either going to freehand your implants or you need your own software to be able to place the implants and figure out your vertical heights and get your guides made, or you send out for a service. And when we use in sequence, we have basically engineers that will help design these cases, get an initial start on placing the implants. Now it is up to me as the surgeon placing the implants to tweak this to my preferences, where I want the implants. In this case, I have them all straight, but they're extra large implants. And this is enough implants to support a full arch prosthetics. And I will have this done very quickly because I'm using all straight abutments. But other cases where the bone is not so good, I'll do angled implants. I see nothing wrong with placing more implants and bigger implants. I just feel these cases are then that much more likely to hold up long term. But in sequence helps guide you through this process. We will have the exact vertical dimensions of your device to meet the specifications. We will make sure, especially looking at those initial photos you took, that the transition line is hidden, and we will know exactly how much bone to remove. And this is the kit you will receive. It starts with the occlusion, and then this metal bone foundation guide will be placed onto the bone and secured into place. And this will never leave until the case is completely done. This will stay there because everything, we will work off of this guide. The kit looks like this. It looks complicated, but there is a step-by-step guide you will receive. And now we're on to the placement. Problem-free implants have to have hard tissue, perfect hard tissue, good enough hard tissue, enough soft tissue, and you have to have the proper positioning to have a long-term implant, an implant that will last forever. I believe that this type of case takes a lot of surgical scale, and something that I encourage you all to start looking into, deciding if you want to do this type of thing. Some of you may not want to do the surgical phases. Some of you may. You will have to become adept at bone grafting. Soft tissue grafting, I feel, is very important at times. Being able to freehand implant is very important at times. We don't always have these implant. Some changes sometimes have to be made. We have to be prepared for surgical changes. To do these cases, you need to have a fully guided implant system. Another thing that I've done and been able to do with InSequence, I have now used 4 different implant systems to do these tooth in a day cases. And InSequence has been able to work with these 4 different systems that I've used. But you have to discuss with your implant representative or the implant company, do they have a fully guided kit? Most do. Do they have the proper prosthetic components to do a tooth in a day case? You need to ask those questions, because you're going to have a large inventory, as I'll show you, of prosthetic components to do these cases. I like this system because there's a stop on the drill, so I don't have to look at the little lines, and I love that it will just stop. And these are some of the prosthetic components. Low profile abutments, very, very critical to do these cases. We need to be able to re-angulate the implants so that they're all parallel by the end. These are very pricey, and the temporary cylinders are what goes into the prosthetic piece, the initial prosthetic device that you're loading. You need to have extra pieces when you do these cases. My opinion is that you need to have a lot of extra pieces when you're working with conventional, because especially if you're freehanding, because you don't know exactly what implants you're placing and what size you're placing. You have to have a lot of prosthetic parts. Your implant, you can order them all from your implant system and then have them, but just make sure you keep track of these abutments and return them when you're done, so that you're not getting stuck with all of these expensive products you're not using. Or an implant system, some implant systems will give them to you on consignment, and then you only pay when you open them up. Now we're going to do a case, and we are nearing the end of our discussion. So let's go through a case. And this is a fairly straightforward case. We're doing an upper arch. It's an excellent candidate to do this. We have good bone. We have bad teeth. We have good attached tissue. Maybe not the best hygiene. The first thing we do is we put in this start bite. Again, I'm doing this case using InSequence. This is a digital case. This is very important to test. Just a final check to make sure that the impressions were done properly. And we always put this in first. And then we will remove the teeth as prescribed by InSequence. We will lay our flaps, identify the nerve, as you can see in this photo. This is a great device where it's called a bone foundation guide. And I love that there are several different checks and balances to make sure these are seated correctly. One is teeth, if you're going to keep teeth, and make sure these teeth are in the proper window. Another check is right here. These are called struts. And these you need to make sure are seated down on the bone. So it's another check and balance, because this is critical. If this is not fully down in the proper position, then everything will be off in your final device, leading to a lot more occlusal adjustments. Another check and balance is to make sure now they're using metal, which is very precisely fitting and married to this bone. So another way you can test that your bone foundation guide is seated all the way. Another method sometimes used is this occlusal method, where the teeth this is a sample of what your final prosthetic will look like, and you actually have the patient bite down into it while seating the device. So it's another check and balance, which sometimes we get with these cases. Next, we remove the bone. We place the stackable system. We place a surgical guide that will pin to your bone foundation guide, and we will drill our implants and place them. You can do your bone grafting at this point.
A little bit. Okay.
I meant to
Unless
turn
the
that
game
sound
go
off.
ahead.
Sorry about that.
Am I blocking the view? No.
Now we will place our low profile abutments, and there are lines sort of showing how they're intended to be placed, so you can place them in the proper position. Now, let me go back to this slide. Now that the low profiles are on, we will torque them down because they will stay on the implants forever. That is the end of the implant phase. The next phase, and all the rest of the components, will be part of the prosthetic phase. So these are the temporary cylinders. These will be luted to the prosthetics. And we place a gasket, and on the right, we place the temporary prosthetic. And again, we pin it to the bone foundation guide so it's in the proper position. There's many different ways to do this. Sometimes I get a prosthetic bite, so I can have the patient bite into the prosthetic bite just to make sure that the occlusion is perfect when I'm luting the temporary cylinders to the device. This is what the device looks like from the occlusal edge on the left. And once I lute it to the device, I unscrew the device and hand it to the chair side assist, and they will take it and start cleaning it up and filling in the voids. At this phase, next time we will discuss much more in-depth detailed surgery and the final restorations and how you do all these things. But I do make a backup temporary. So we make a second one while the lab person is finalizing the device. And after that, do my grafting, put on these little healing domes while I stitch. And by the time I'm finished stitching, a lot of times these devices are ready. And this is what is happening in the other room. And now we insert the device. Typically, the occlusion is really nice, and it does require some occlusal adjustments. And I do initial occlusal adjustment in the office, and then I have the restorative doctor I'm working with do another set of occlusal adjustments anywhere from a few days later to a week later. And we can achieve this every time. And the smile line is hidden. The transition line is hidden above the smile line every time. So